right, and then Dr. Lieu, I'm going to introduce you. All right, good morning, everybody. Welcome to our April Colorectal Cancer Task Force meeting. This morning we have a presentation from Dr. Chris Lieu. He joined the University of Colorado School of Medicine faculty in July of 2011. He trained in internal medicine at the University of Colorado, where he also served as a chief medical resident. He completed his fellowship training in medical oncology at the University of Texas MD Anderson Cancer Center and served as the chief medical oncology fellow while he was there. He currently serves as the director of GI medical oncology at the University of Colorado Cancer Center, the vice chair of the National Cancer Institute Colon Cancer Task Force, and he serves on the National Comprehensive Cancer Network panel for neuroendocrine cancers. So without further ado, we will let Dr. Lieu take it away.
All right, thanks so much, Ian, and thanks to the Colorado Cancer Coalition for allowing me to give a quick update on biomarker testing for colorectal cancer and also a quick COVID-19 update, because no talk these days would certainly be allowed to be done without talking about that as well. But these are my disclosures, none of which have any bearing on any of the things I'm going to present over the next 20 minutes. So what are we going to talk about? For colorectal cancer, this is going to be a little bit more of a general talk, but hopefully we'll give everybody on the call a general idea of how we use biomarkers and biomarker testing to impact the treatment of our patients with colorectal cancer. And so we'll discuss very briefly what a biomarker is and how biomarkers can affect the treatment of colorectal cancer. And we'll give some examples of meaningful biomarkers for colorectal cancer. This is the area that I'll go a little bit quicker on, but just to kind of give you a sense of how we use certain biomarkers to impact treatment decision-making for our patients with colorectal cancer. But Ian will send out the slides, I believe, after this talk, so I apologize if I go through this a little bit quicker. And then, of course, a quick COVID-19 update to tell you where we are in Colorado. So whenever we talk about personalized medicine, it essentially is a term that's probably overused, but really just basically comes down to a simple point, and that is we need to individualize our medical treatment plans. And I'll talk about this a little bit more in the future in the next couple of slides, but we shouldn't really be too surprised if we try a one-size-fits-all treatment for everybody with a particular cancer, and we shouldn't be surprised if it works for some people and doesn't work for others. And so what are some of the steps that we can take to identify patients that might actually benefit the most from the treatments that we currently have? So when we talk about anybody with cancer, it really kind of boils down to three essential types of treatment. We can either take it out with surgery, we can radiate it with radiotherapy, or we can provide some type of systemic therapy to treat cancer. And so that includes chemotherapy, which kind of was initially designed around the era of World War II, actually, with chemical warfare. And that's where chemotherapy really kind of came about, was this idea that, well, you can actually kill rapidly dividing cells, which is the problem with cancer, with a toxic drug like chemotherapy. But obviously what we're really focused on now is this idea of targeted or immunotherapy. And so chemotherapy, if we kind of think about it in more general terms, just kills cells by, killing rapidly dividing cells. And so we shouldn't be also surprised in that situation where we may be able to target cancer cells, but there's also a lot of collateral damage. And I kind of liken this to an unguided bomb that you might hit your target, but you have a lot of surrounding damage as well. Targeted therapy and immunotherapy are the new weapons that we have to fight cancer. They really work by targeting specific genes or proteins that are altered in cancer cells. Sometimes we're targeting specific growth factor pathways, and I'll show you examples of that. And sometimes we're trying to enhance the immune system to be able to recognize cancer and fight it for us. And a lot of these targeted therapies and immunotherapies can be used alone or in combination with chemotherapy. So it's really interesting that from 1957 to 1997, there's really only one FDA-approved drug to treat colorectal cancer, and that was the number one drug that you see on this list, 5-fluorouracil. And really from 1997 up until now, there are now 15 FDA-approved drugs, and some of them are what we consider to be traditional cytotoxic chemotherapy, such as the top 5 that you see there. But you can see a kind of a virtual explosion of biologic and targeted therapy. Some of these are very similar to each other, to kind of Me Too drugs, but still a decent amount of FDA-approved biologic and targeted therapy, including some immunotherapy drugs on the very bottom of this list. And what's interesting about this is that this year I expect this this number to actually grow to 17 FDA-approved drugs, and we'll talk about that in a little bit as well. We also know that colorectal cancer is expensive. So for 5-fluorouracil, which is the top drug that you see on this list, $45 per dose, which is very affordable, and this is a drug that's literally been around for about 50 or 60 years. But kind of compare that to, say, regorafenib, which is further down on the list at $20,000 every month, or some of the immunotherapy drugs that have received a lot of hype. These are extremely expensive drugs. So when we talk about approving FDA approval for colorectal cancer drugs, we want to make sure, obviously, that they're effective, but that they're cost-effective as well. And so we don't want incremental benefits if we're going to be paying this kind of money to treat our patients. We want these big magnitude benefits, and I'll talk about that in a little bit as well. So I alluded to this earlier, but what we really want to get away from is this one-size-fits-all treatment strategy for cancer, and this was kind of the best that we could do from the 1960s all the way up to the early 2000s. But again, if I give you 5 patients that have a diagnosis of colorectal cancer, we know that those 5 patients are all different. They all have different environmental exposures. We can tell you that their cancers are indeed different as well if we do mutational profiles on them. And so we shouldn't be surprised at all when our treatments work really, really great for a certain patient, then for the other 4 out of 5 patients, they may not work at all. And so we want to get away from a one-size-fits-all treatment to a more personalized type of therapy. So how do we do that? We do that via looking for biomarkers. And so biomarkers is a short term for biological markers, which really can be found in blood, body fluids, or tissues, and oftentimes from the tumor itself. But once biomarker testing is done, it might tell you a little bit about whether the cell function in that area is normal or abnormal. It can tell you how aggressive a cancer is, and so we talk a lot about that in terms of prognosis, how likely a cancer is to be aggressive versus not aggressive. It can predict the likelihood of a cancer's response to a specific treatment plan, and that's certainly something that we're very, very interested in. And it can help a patient and their doctor make decisions about care. I want to differentiate tumor biomarker testing versus genetic testing because they are 2 very different things, and we can talk about mutation testing in terms of a tumor, or we can talk about mutation testing in terms of the genes that you're inherited with. So biomarkers are particular abnormalities or rearrangements that are found in the cancer cells that are different than the normal cells. So if a doctor talks about next-generation sequencing, they're really talking about testing the tumor and doing a mutational profile of that tumor. And that's separate from genetic testing, which are the genes that we inherit from our parents. And so this is the genetic sequence of DNA that we're born with. And a lot of times genetic testing is performed either through a saliva test or through a simple blood draw. But these are 2 very distinct things. And for most of what I'm going to talk about in the over the next 15 minutes is really going to be kind of biomarker or tumor testing of these mutations. And so this is a very kind of simplistic slide, but if we do a biomarker testing on any patient that has a tumor of colorectal cancer, if we talk about it being biomarker negative, it traditionally means that there's no mutation or no alteration. And another way we might call that is a wild type. So the mutation is wild type, which means that there's no mutation, or the gene has no mutation, and then it's biomarker negative. If we say a tumor has a biomarker positive gene, then that's typically an altered gene. Either there's an alteration in its DNA, a mutation, or even an amplification of a particular gene. So one of the ways we use biomarkers to treat colorectal cancer is through biomarker testing of several of the genes that you're actually seeing on this list here. So there are 2 FDA-approved drugs that target something called epidermal growth factor receptor, or EGFR. And so there's a drug called cetuximab that was approved in 2004 and panitumumab that was approved in 2006. And what you see here is a monoclonal antibody, which is kind of at the top of this figure, and you see this blocking or attaching to this receptor called the epidermal growth factor receptor. And the idea is that colorectal cancer uses this pathway to stimulate a lot of the things that makes colorectal cancer bad, like cell survival, proliferation, development of blood vessels, metastasis, and cell motility. And so the idea that if you block off this pathway with an antibody, you should be able to block all this downstream signaling and hopefully stop the growth of this cancer. One of the things that we also know is that, well, if they're activating mutations downstream of this receptor, so even if you cut off the water flow here, but you have an active faucet right here in a gene called KRAS or NRAS, then the concern is that, well, even if you block the water flow here, then the water will flow continuously down here because you've just blocked too high in the stream. And so one of the genes that researchers looked at after they developed this drug was to look at KRAS and NRAS mutations to see, well, even if we give patients this drug, if they have a mutation downstream of that, will it impact their survivability and their response to this medication? And that's what we saw. And so really the era of biomarker testing for colorectal cancer began in 2008. And so what they found was that if a patient had a KRAS or an NRAS mutation, they were very unlikely to receive any benefit. So in this clinical trial, patients with refractory metastatic colorectal cancer were randomized to receive cetuximab or just best supportive care alone. If they had a mutation in the gene called KRAS, they did no better than the patients that received best supportive care alone, which means that they're deriving no benefit, but they were receiving side effects from the drug. Compare that to patients that had wild-type KRAS, and you saw that they did much, much better than patients that received best supportive care alone. And so the take-home message that we got from this particular study was that if you had a RAS mutation, we shouldn't be giving these patients EGFR inhibitors because they're not going to receive any benefit, but they certainly are going to receive all the toxic side effects. And so this really kind of kicked off the era of biomarker testing, and this was roughly about 12 years ago, and certainly something that we require now all patients to be tested for prior to initiation of this treatment. Well, what about biomarkers beyond RAS? I'm going to talk about a particular mutation called a BRAF V600E mutation. So where RAF sits in this signaling pathway is right downstream of RAS. And so the idea is the same. If you cut off all the water flow here, but you have an activating mutation in RAF, the concern is that, again, the patients are going to get the drug, get side effects, but receive no benefit. What we found is that the BRAF mutation is a very negative prognostic factor. That's just a way of saying that these tumors behave very, very aggressively. And it seems like these tumors are very, very resistant to the current treatments that we have. And so this has really been perplexing for a lot of doctors that treat colorectal cancer because we give these patients with a BRAF mutation all the drugs that we have, but none of them seem to work, and the tumor seems to grow completely uninhibited, which means that it shows that this type of cancer has bad biology. Fortunately, this is still a minority of our patients that have this BRAF mutation. It's only about 5 to 10%. But this is an area where we knew that we needed to get better drugs and that our current therapies were very, very ineffective. Interestingly, the same BRAF mutation with a mutation in the exact same spot is seen in melanoma. And so this idea of finding a mutation and having a drug, and here the drug is called vemurafenib, that can target the BRAF gene was developed in kind of around 2009, 2010. And this idea that if you find a mutation and you have a medication that can hit the mutation, you might have a really dramatic response. And that's what they saw in skin cancer. So what you're seeing is a PET scan, and all the dark spots are areas of cancer. And after 6 weeks of treatment with a BRAF inhibitor for a patient with metastatic melanoma, you see the PET scan on the right, which is just after 6 weeks of therapy. What does that look like in a patient that has this disease? Here you can see a patient that's obviously had a lot of weight loss due to cancer. You can see all these tumors on the chest wall kind of scattered all about. And after 6 weeks of therapy, what you see here is a completely different looking person. I promise you that this is the same person, but really was kind of this proof in principle that if you had a gene and could personalize a gene that was mutated and you could personalize therapy to receive a drug that could hit that gene, sometimes the results could be dramatic. Well, this is what we saw in skin cancer. Interestingly, when we tried this exact same drug in patients with BRAF mutated colorectal cancer, instead of a response rate of 60 to 80%, we only saw a response rate of 5%. So basically, 1 out of these 19 patients had a good response to the drug, which meant that even though we had the same biomarker in skin cancer and colorectal cancer, we had 2 very, very different responses to the drug. This is where laboratory science and a lot of the research that we do and all the cancer centers across the world really make a difference. And what we found was that when you knock out this gene in BRAF, the tumor is very, very smart. It actually signals back through EGFR and reactivates this pathway. And we found this out in preclinical models, and so this was studies done really in the lab. And so the idea was, well, if there's a feedback loop that is present in colorectal cancer that is not present in melanoma, maybe we need to change the way we attack this particular mutation in colorectal cancer. And so there was a study that took out chemotherapy and basically just used targeted therapy, take out the BRAF gene, take out a gene downstream of BRAF, and also take out the feedback loop through EGFR. And so this is what we call triplet targeted therapy for patients with BRAF mutated colorectal cancer. And when we did the initial phase 1 study, and this was a worldwide study of a triplet combination of targeted therapy, you can see these dramatic tumor responses. Some of these patients actually had what we call a complete response to therapy, where after starting therapy, they had no evidence of any metastatic disease. And so the response rate was much, much better. And the reason why I said that there are 15 FDA-approved drugs currently, and I expect it to be 17 FDA-approved drugs this year, is because this is currently at the FDA. We know that this improves overall survival for our patients with BRAF mutated colorectal cancer. And so this actually now shows up in the latest NCCN guidelines where we should be testing for this gene. If the patients have a mutation in BRAF, they should be receiving targeted therapy. So this is 2 targeted agents. It does not include chemotherapy. And this is a new treatment option for patients with BRAF mutated colorectal cancer. Moving on, we can talk about whether or not right or left-sided colon cancer can be a biomarker. So just the side that your colon cancer develops on can be a biomarker. It's funny, when I was at MD Anderson, there are like literally 20 medical oncologists that only see colorectal cancer. And so the joke always went that maybe we should be dividing it up, these 20 oncologists, between right-sided colon cancer doctors and left-sided colon cancer doctors. And these are the jokes that you get when you're at a big institution like MD Anderson and you're with a bunch of oncologists. But the ironic thing here is that right and left colon cancer actually do behave differently biologically. And what we found was that if you develop a cancer on the left, you actually have better response to EGFR inhibitors than if you develop a cancer on the right. And so we actually use the side that the cancer develops on as a biomarker. And so patients with right-sided colon cancer, they did not benefit from treatment with a targeted therapy, an EGFR inhibitor, even if the patients were KRAS or NRAS wild type. So believe it or not, we actually use this information to determine our treatment for patients with metastatic colorectal cancer. If they have a right-sided primary tumor, I do not offer them an EGFR inhibitor in the frontline setting, and this is the data that proves that. So this is actually a very cheap biomarker because it costs you absolutely nothing to have this information. I'm going to wrap up with immunotherapy. Certainly one of the hallmarks of cancer is this ability of cancer to evade immune destruction. If we have a mutated tumor cell, our immune system should be able to recognize it and kill it. And so we know that this dysfunction of the immune system is one of the hallmarks of cancer. Microsatellite instability high colorectal cancer, or what we call MSI high colorectal cancer, is a biomarker that we now use to determine whether or not a patient might actually be responsive to immunotherapy. I'm going to talk about something called mismatch repair, and really it's a very, very simple concept. Everybody on this call, everybody in the world replicates their DNA every single day. And if I asked you to transcribe all of the novel War and Peace on Microsoft Word and to ask you to do that with an intact spell checker, you probably have a handful of typos, but the spell checker would catch most of the typos. And that's the same thing that happens in DNA replication in our bodies every single day. We replicate DNA. The number 2 part of the figure here shows you that sometimes we have a typo in our DNA. Our bodies have to be able to recognize that typo, unwind the DNA, fix the typo, and then wind it back up. And that's just called mismatch repair. Now imagine if I asked you to transcribe War and Peace on Microsoft Word without spell check. Now instead of a handful of typos, you're going to have a ton of typos. And so sometimes the spell checker can be broken in the tumor. Sometimes you inherit this defect in the spell checker from your parents. And so what you find is that a normal colorectal cancer that has an intact spell checker has about 30 to 70 mutations in it. If you have a defect in mismatch repair, just like transcribing War and Peace on Microsoft Word without a spell checker, you have a ton of typos. And so these mismatch repair deficient tumors have over 1,600 mutations in their tumor, making them very, very, very bizarre when you look at it under a microscope. What's interesting about this is that if you have a tumor that has that many mutations, your immune system actually recognizes that something really, really bad is going on. And so when you stain these tumors, here in this figure, in figure B, you can actually see all these dark stained cells are tumor-infiltrating lymphocytes. They are there to try and kill the cancer, but the cancer has figured out a way to turn them off. Like I said, for mismatch repair, you can either inherit this from your parents or the tumor can acquire it on its own. There are a couple of ways that we test for mismatch repair, but all of these things are recommended to test whether you have stage 1 or stage 4 cancer. If you inherit this defect from your parents, it's actually something called hereditary non-polyposis colorectal cancer or Lynch syndrome, which gives you an increased lifetime risk for various cancers, including colorectal cancer. We know that this is prevalent about 15 to 20% in stage 2, but in stage 4, unfortunately, it's only about 4 or 5% of our patient population, but it's a critically important patient population because if you find this out of 1 out of every 20 patients that you treat, the significance in terms of being able to offer them immunotherapy can be huge. So there is an immunotherapy called pembrolizumab, which blocks something called programmed death ligand receptor 1. And this idea is that if you have a T cell that has this ligand PD-1 and a tumor cell that expresses this receptor called PD-L1, and that's what you're seeing here, it's a mechanism that basically tells the T cell, turn off, don't kill me. And this is one of the ways the tumor cell avoids killing by a T cell. If you have an antibody that can block this interaction so that that interaction is no longer made, it turns on tumor cell killing. So what we saw in MSI-high colorectal cancer, and that's all these green bars, are just dramatic tumor reductions, some of which resulted in complete responses. What this means is that you saw a tumor on a CT scan. After roughly about, you can see a year of treatment, they could no longer see any disease, which meant that for all intents and purposes, you got rid of all the stage 4 cancer. And there's 2 important points here. Number 1, you can see that almost every patient had some kind of response that had MSI-high colorectal cancer. That's these green bars. The other take-home point is that if you didn't have MSI-high colorectal cancer or you tested negative for this biomarker, you're very unlikely to respond to immunotherapy. And then the third take-home point is that look at the duration of these responses, going out to over 2 years. And that's actually where the study stopped. And a lot of these patients haven't required to have retreatment. They had that good of a response to this immunotherapy that they currently aren't being treated for their colorectal cancer now over 2 years out. There are other immunotherapies. This is a combination of 2 immunotherapy drugs where you saw very, very impressive responses. In a couple of months, they're going to present data on using immunotherapy frontline for this 5% of patients that have MSI-high colorectal cancer. And they're going to show you, because the press release came out this weekend, that immunotherapy beat chemotherapy in this small but very, very important subset of patients with metastatic colorectal cancer. This is also one of the first ever tissue agnostic indications for any chemotherapy or any targeted therapy drug. So if you have this biomarker, it's not only approved for colorectal cancer, but any cancer, which is a very, very, very neat approval indication. So to take home point, MSI-high colorectal cancer does predict for benefit from immunotherapy, and this is why, again, this biomarker is so critical to be tested in all of our patients. So to kind of wrap up this section, biomarkers may direct cancer treatment. Each patient's mutational makeup of his or her tumor is very, very unique. And knowing these tumors' biomarkers, the mutational status of these tumors, can really help a physician select the most effective and appropriate treatment. We always tell our patients to ask their doctors about biomarker testing. Has my tumor been tested for biomarkers? How will the biomarker status affect my treatment plan? The rate of testing for patients with metastatic colorectal cancer is really all over the board. Some analyses suggest that only half of our patients are being tested for appropriate biomarkers. I personally believe that that is much higher than that, but still, to put this in the hands of the doctors is important, but more importantly, if we put this in the hands of our patients to ask their doctor about biomarker testing, I think can really make a much, much bigger difference and can certainly inform our patients and make sure our patients are part of developing their own personalized treatment plan. Give you a very, very brief update on COVID-19. These are just numbers from today at 6:26 a.m. There are roughly 1.5 million confirmed cases. Just a really unfortunate amount of deaths around the world, 90,000. If you want to, and these numbers continue to go up, but you're actually starting to see some countries, including the United States, maybe starting to reach their peak. And so we're really hoping to see that over the next couple of weeks of countries hitting their peak and then hopefully starting to see the impact of social distancing on the number of cases confirmed. If you look at Colorado, certainly nowhere near the amount of cases that are seen in other states, particularly New York, but there are 5,655 confirmed cases, 193 deaths. I can tell you at the University of Colorado Hospital, as of yesterday, we had about 120 admitted patients. 62 of them were in the ICU and on a ventilator. I will tell you that I am cautiously optimistic that over the next couple of weeks that maybe we've seen a little bit of a plateau, but it's still very, very too early to tell. And I will tell you that I don't want to kind of overstate the optimism here, but I think we are starting to see the impact of social distancing. I'm also really, really imploring people to continue to do what they're doing, because if you let up now, then you're likely to see a second peak if we don't continue doing what we're doing. Just in terms of special considerations for patients with cancer, I know I'm going a little bit over, but I'll make this fairly quick. We're still telling our patients to receive treatment as planned unless otherwise notified by their care team. I'm encouraging all of our patients to have a conversation with their doctor and their care team about the benefits and risks of continuing treatment versus delaying treatment or reducing treatment. For patients that are currently in surveillance, in other words, not actively treating cancer, a lot of times we've postponed these visits, but really we've moved significantly to virtual health visits. We have gone from 0 to 100 miles per hour in terms of virtual health visits, and it's really pushed us into a really modern age of care. And so you've seen the University of Colorado Hospital, along with all of our hospitals in the Denver metro area and beyond, really push towards telehealth visits. CDC guidelines now recommends using a mask in public. Keep in mind that not all patients with cancer are severely immunocompromised. Most healthcare institutions, and I would say definitely all in Colorado, are postponing elective and non-critical procedures, and this includes for patients with colorectal cancer screening colonoscopies. What about clinical trials? Patients that are currently enrolled on clinical trials are continuing as planned, and I think this is true for not only our cancer center, but others in the state. Patients seeking to enroll into clinical trials may experience delays, but we are still enrolling patients here, and I know other clinical trial institutions in the state are continuing, albeit probably slower than normal. The good news is that I think that our state has really taken very, very quick action, and I think we're seeing the benefit of that. Obviously, we still have too many infections, but I think it could be a lot worse. And we certainly have advantages now that we may not have even had about 5 or 10 years ago when you think about our ability to have groceries and medications and supplies delivered directly to our house. So I'll leave it up for any questions or any points of discussion. Just to give you guys some links, there are support, there is support available from numerous institutions, but also from the American Cancer Society and the University of Colorado Cancer Center as well. So I'll turn it back over to Ian. Thank you, guys.
Great. Thanks, Dr. Lieu. That was wonderful. So we probably have time for like 1 or 2 questions. Does anybody have anything?
Hey, Ian, this is Doug.
Morning, Doug.
Morning. Dr. Lieu, thanks for the presentation. I'm just curious, right now with all non-urgent procedures, including, like you said, screening colonoscopies not being performed, do you see that potentially impacting approach to colorectal cancer screening in the long term?
Yeah, that's a great question. I mean, we're delaying colonoscopies for 2 groups of people, right? People who normally need their screening, and people that have previously had a diagnosis of colorectal cancer and need to get colonoscopies for their secondary prevention of colorectal cancer. I think that things that can be done right now are probably stool-based tests, right? Because those can oftentimes be mailed to patients and probably represent the next best thing, because we consider obviously colonoscopy to be the gold standard. This also includes virtual colonoscopies, right? Because those aren't being scheduled either. The problem is that if those tests come out positive, then really can you get a colonoscopy? And my hope is that the delay will be shorter than what we're hoping or expecting. But this also means that everybody that needs a colonoscopy right now is going to be pushed out to the future, which means the summertime, you could see a crush of people getting CT scans, MRIs, and colonoscopies and not being able to get in that way. So you can kind of think about the downstream ramifications of this being quite extensive. So I think it's going to make for a very, very busy time once the restrictions start to ease. But I think it's probably going to delay things. My guess is for 6 months to maybe even up to a year. But I think doctors and hospitals are going to be very, very busy once things start to let up a little bit.
Good question, Doug. Anybody else?
Dr. Lieu, this is Kendra Mitchell. I just wanted to say thank you for all the amazing work you're doing. I'm a stage 1 survivor myself, and I've heard you speak several times, and you're always at our Alliance walk, and it's just really important the work you're doing, and I appreciate you taking the time to share it with us today.
No, thanks so much, and certainly thanks for joining the call and being interested and supporting the efforts of the Colorado Cancer Coalition, for sure.
All right.
All right, guys, I appreciate it.
Thanks, Dr. Lieu.
Guys.
Appreciate it.
Stay safe. Yep.
Thank you. All right, I'm going to stop recording.